Good evening, doctors. My name is Rakesh Sonone, and on the behalf of FDC and MedTalks, I welcome you all to yet another episode of 52 Weeks Diabetes Essential by Dr. Sanjay Karla, Chairperson, Education Working Group, International Society of Endocrinology, and past President, South Asian Federation of Endocrine Societies. And today's topic is diabetes and female sexuality. Before going ahead, I just want to announce last week quiz winners. They are as follows: Shantanu Kumar Bhattacharya from Kolkata, West Bengal; Prachita Srivastav, Thane, Maharashtra; Rajiv Handa from Delhi; Gangadhar Rath from Bhubaneswar; Naga Rani from Nizamabad; Bharat Mittakola from Surat; Anand Purandare from Mumbai, Ravi Bhatt from Sirsi, Kaval Saluja from Mumbai, Shashi Khare from Bhopal, Rakesh Bhargav from Delhi, Ashwini Kumar from Kanpur, Atul Doshi from Mumbai, Rajesh Wadode from Aurangabad, Dr. Vilas Sonone from Asti, Dr. Sanjeev Puri from Oshiarpur, and Dr. Pradeep Patro from Chandrapur. With this, I would like to hand over this topic, today's lecture to Dr. Sanjay Karla, sir. Thank you.
Thank you, Mr. Rakesh, and good evening, everybody. All of us who are logged in from various parts of the country. I noticed Dr. Gauri Shankar from Karnataka, Dr. Manu Sharma from New Delhi, and Dr. Ajay Kumar Lal from Kolkata. So, if there is one thing that we are all united in, all across India, that is our common desire to improve the health of people living with diabetes. That's why we meet every Sunday evening at 9 p.m. to talk about diabetes essentials, to talk about what is essential for good quality diabetes care. These months, we've been talking about glucocrinology, that is the relationship of diabetes with various endocrine glands, with endocrine function and dysfunction. And today we have a special topic. We'll be talking about female sexuality, female sexual dysfunction, and diabetes. For this very difficult, very unique topic, please allow me to welcome my better half, the expert in this field. Warm welcome to Dr. Bharti Kalra.
Hello, Scotty. Good evening.
Dr. Bharti Kalra is a gynecologist working at Karnal in Haryana, and she is also a qualified sexologist, having become the first gynecologist of the country to do the prestigious fellowship in sexual medicine from Maharashtra University of Health Sciences. Now, sexuality is an essential part of life. It's necessary for reproduction, it's necessary for health. But female sexual dysfunction is something that we rarely talk about. And even in Diabetes Essentials, Dr. Bharti, this is the first time we are broaching this topic. So, would you like to share your slides with us? And while you are speaking with us, would you like to tell us about your journey in the field of sexual medicine and how has that impacted the health of your patients?
Good evening. In my practice, I find the I am being a gynecologist because in day-to-day practice, I come across many patients, whether spoken or unspoken, they have desire to know about their sexuality and its impact on their life. And this is especially important in the patients of diabetes because at times they don't want to convey their feelings and they want their doctor should know from their indirect cues that they want to convey that they have sexual problem with their partner and they find it difficult, may it be because of their diabetes or it's just from their general health. So, if we touch upon that topic and we discuss about their sexual health, means their intimate health with their partner, they feel very much obliged and they feel happy that this unspoken, unexplained thing has been told to them and it has made them very comfortable with their doctor. So, if we discuss this aspect of female life or especially the couple's life, that will improve our practice also and it will make us comfortable to if we go in more and more in our practice and we ask more and more questions, we gain confidence that is for ourselves also that we will be comfortable talking to the patients about it and patients will be more open to it and that will improve our practice also and our patient satisfaction. So knowing through this background, we will discuss that what are the aspects about the sexual health which are impacted by diabetes and how it affects the control of diabetes. So, sexual health is a complex biopsychosocial process. It is biological processes involved in it, and in patients of diabetes, and which may be affecting their CVS, CNS, endocrine functions, or the medications they are taking for it, or they might be suffering from sexually transmitted diseases. So that is the biological aspect which affects their sexuality. Or the person might have any history of abuse, sexual abuse, or she might be having any relationship problem with her partner and under psychological stress. Sometimes the newly diagnosed diabetics, they feel low in their esteem, and that impacts directly on their sexual health. At times, they have psychiatric disorders, or there is any history of past trauma which just comes to their thought process. And when they are with their partner, they just go into those thoughts and they don't get involved. And if diabetes is there, there is some biological component which is affecting their sexuality. And if above it, there is a psychological aspect, so that impacts their performance a lot. That means it worsens it. So, as far as the prevalence is concerned, in type 2 diabetes, more than 50% of women have sexual dysfunction. And it has been seen that in premenopausal women, roughly 40%, and postmenopausal means more than 60% women are affected. And when the studies were conducted, it was noted that the age factor, the metabolic syndrome associated with diabetes, or atherogenic dyslipidemia, these three were the strongly associated factors leading to sexual dysfunction. So, this shows if age is more, or metabolic dysfunction is there, or atherogenesis is there in our lab reports and in on clinical examination of our patient, it's preferable that we should touch upon this topic in their health management also. And if we talk about the type 1 diabetes, roughly 30 to 40% patients are affected with the sexual dysfunction. There is a DSM classification, DSM 5 classification for female sexual dysfunction, which divides the sexual dysfunction into three aspects. First one is the sexual interest and arousal disorder. Then comes the orgasmic disorder, and might be having the genitopelvic pain and penetration disorder. So we will discuss all these separately. All have either overlapping management, but discrete management for if individual disorder is there, that is also is to be taken care of. So in diabetes, the commonest is desire and arousal disorder. And the diminished clitoral sensation is seen in roughly 60% of patients. And around 50% of women complain that they don't achieve orgasm. Although orgasmic dysfunction is otherwise in general population also it is very common, because some women might not have achieved orgasm at all during their sexual life, or it might have been any occasional incident. But if they have diabetes along with it, the dysfunction worsens. Depression might be a cause, and vaginal discomfort and dyspareunia. And if age is more, vaginal dryness is a common cause. That means the estropenia, estrogen deficiency in perimenopausal and postmenopausal women, that is a common cause, especially seen in diabetic women. So if we go about the risk factors, most important is the age, type and duration of diabetes, complications of diabetes like neuropathy, vasculopathy, and comorbidities. If someone is having thyroid dysfunction along with diabetes, so both together they worsen the condition. And she is taking concomitant medications which may be affecting her sexuality. And in the phase of life, sometimes if there is some promotion or financial loss or sudden the stress of a family, like children are going out, and the lady has to take care of the all family work, household work, she gets tired. Means if she's in a hectic phase of life, she might not be considering sexual health as an important aspect, and which might be affecting her interpersonal relationship. And specific to diabetes is the psychosomatic cause. It has been seen, especially in type 1 diabetes, those who are using the girls who are using the continuous CGM devices they are using, or insulin infusion, insulin pump are using, they have body image issues. Sometimes they are very lean because of worse control, means the type 1 diabetes if they are very lean, or in type 2 diabetes if they are very obese, they have body image issues. Sometimes the PCOS is along with the diabetes, they might be having hirsutism, acne. So these are the issues. They don't like to be sexual. Insulin pump, already said, and they have somatized anxiety symptoms. Quality of life is affected, and interpersonal relationship is also affected because of this management aspect of diabetes. And if the person is having vascular or neurological complications, as is say that it has a biological component in diabetes management, the effect of diabetes. If there is uncontrolled diabetes leading to complications, the common complications like neuropathy, because the phases of sexual activity, just like the first is excitement, then lubrication, then orgasm, then the resolution phase. So all these phases in which the, especially the lubrication, that is depending upon the autonomic function. So if there is autonomic dysfunction, or if there is sensory dysfunction or motor dysfunction, the ladies because of motor dysfunction, and if she is overworked, she gets fatigued and she is not able to cooperate. So all these conditions lead to the difficulty in being sexual, and sexual activity is affected. Or if there is peripheral arterial disease or coronary artery disease. So all these things lead to reduced vaginal lubrication, decreased libido, and moreover the lack of orgasm. So if sexual satisfaction is not there because of lack of orgasm, the person doesn't want to be sexual again. So the lack of sexual activity reduces the lubrication, and the vicious cycle of negative feelings and the negative impact of on sexuality happens. So the comorbid conditions like vaginal infections, means candida, trichomoniasis, bacterial vaginosis, these are the common vaginal infections, and which have to be treated if these are there. Or syndromic approach can be given to them. Syndromic medication can be given if we are unable to examine them, or they are just complaining of young diabetic woman. She is complaining of itching over genitalia, means pruritus vulva, or itching in vagina. So then we can give them therapeutic trial of, if we have not examined her, we can give her therapeutic trial of syndromic treatment for her vaginal infections in the form of tablets and vaginal pessaries. If she doesn't improve and we are unable to examine her, then we should get her examined for her local condition. And if there is decreased vaginal lubrication, and tenderness is also there. So it happens, there is vaginal and vulval itching. Patient does itching. Because of itching, when she passes urine, she gets burning. Then because with the itching and burning, then she gets the soreness of genitalia and tenderness. So this vicious cycle also goes on. So we have to pinpoint the problem and treat it. And most common is the nutritional deficiency. We don't take care of our health in the form of nutrition. Commonly, ladies, when they are busy with their household work, busy with their profession, they just ignore themselves, and they just say, because of day all day hectic schedule, they just get tired and don't feel like being sexual. So if we supplement them, empirically supplement them with the calcium, vitamin D, and give them neurotropic vitamin B, that gives a very good response. So if she is on concomitant medication like antihypertensives, lipid lowering, diuretics, SGLT2 inhibitors, and the common ones are commonly antihistaminics, just like cetirizine, that is day in and day out, OTC preparation. Many of the patients are taking it without knowing and without informing their doctor. They are taking H2 blocker is also used. That use is very common. So these two things, as I say that if you have taken it for a running nose antihistaminic, it has dried up your nasal secretions. Similarly, the same action happens in the vagina. It dries up the secretions, and the penetrative sex becomes painful. Dyspareunia happens, and again the cycle of sexual dysfunction starts. Many a times the patient come when I had taken medication and antibiotics 15-20 days back. After that, I am having difficulty in being sexual. And with the use of oral contraceptives, sometimes because the vaginal secretions are reduced because of the monotony for the throughout the cycle, the hormone levels remain same, so they don't like to become sexual. So these are the additional things which we should ask in their history, and we should look for in their prescription. If we are using these things and patient has sexual complaints, we should change the medication to the less with the medication with the less side effects. So the question comes, when to suspect. In our busy OPDs, is it possible that we should ask each and every patient that, do you have any sexual problem? We know this is not practical, this is not feasible, this is so much time consuming, and many a times, this being a very sensitive topic, the person may not like to volunteer. How we can suspect that patient might be having sexual problem? We should look for it and specifically ask for it in the vulnerable group. Means, like those who have unexplained poor glycemic control, we have given them all the medications for good glycemic control, but they are unable to achieve it. Or she presents with vague complaints, just like in every visit she complains of lower abdomen pain. This might be she wants to convey indirectly that we should ask her the sexual life questions, but sometimes we are ignorant, or we are hesitant, we are unable to ask. Or if she comes with the depressive symptoms and just conveys, I'm not happy, or I'm not in relationship with my husband, so then we should ask it in detail. Or if she presents with the macrovascular complications of diabetes. So in all these groups, if possible, we can ask them directly the question. Even if she comes with a negative answer, she doesn't reply that she has this problem. It might be possible that in next visit she volunteer her information. It happens very commonly that if we ask for the first time a particular question, the answer is no, and in next time patient herself says that I have this problem. At times, if patient is not volunteering, we can take the help of her partner. We can ask her husband or partner whether how is your personal life. I just commonly ask this question: how is your personal life, or how is your relationship with your partner? So ladies come up with the answers, and clues are given to us so that we can go for further questioning and getting the reply. And what we want to know and how we want to treat, that we get the cues. So we should screen and substantiate our diagnosis. Once we have suspected she needs treatment for her sexual ill health, so there is one standard questionnaire, that is female sexual function index, that we can give to them, and Beck's depression inventory. In diabetes, they're commonly seen that there is underlying depressive symptoms. It might not be the full-fledged depression, but the symptoms of depression are there. We can give them questionnaire. If they are unable to talk to you directly, they can just give that yes or no in the form of answers, and we can see that which area is the problematic area. Then indirectly we can prescribe her. Means sometimes, because of, at least in Indian society, ladies don't want to talk about their sexual health even to the gynecologist, female gynecologist. So it's very difficult if we say that they will talk to the male gynecologist. But at times this questionnaire are very helpful, and taking help of their partner, that is also very helpful. The history and examination, if it is needed, history we have asked in the questions, and examination, if feasible, we must do it. If it is not feasible, then we can give her, depending upon her complaints, we can give her empirical therapy, and in next visit we can examine her, get her examined if it's not possible in the first visit. We should look for the phases of involvement, whether it is lack of lubrication, or lack of orgasm, or she gets dyspareunia, or she gets, if she might be having vaginismus, secondary vaginismus may be there. So we should know the phase of involvement. Try to localize, pinpoint the etiology of it and contributing factors, and relevant investigations must be done if these are needed, just like TSH levels, prolactin. And if she gets frequent dyspareunia, deep dyspareunia is there, must get her ultrasound to rule out endometriosis or any fibroid or any other PID like pathology. So once we have identified, and then we have to, this is the biomedical part. We had looked for it in history and examination and investigations. Now, once we have identified the phase of involvement, we should assess and optimize her psychosocial factors. Just like sudden change in personal and professional life, sometimes in a job, the person gets promotion, then the additional stress is there of her job, long working hours, just like in bank duties, the sometimes the patients come that we have long working hours, we go to the bank in 8 a.m., we come back at 9 a.m., so we don't get time. Or otherwise in other duties, if they are posted far at a far off place, then they are unable to get time, relaxed time for sexual activity. If someone is under stress, maybe because of physical reasons or maybe because of emotional or professional reasons, so sexual life is the first thing to be affected. We should optimize her glucometabolic control and review and optimize her concomitant medication which might be affecting her. And if all these things are under control and we are not getting a good response, then the specific therapy can be given depending upon her age group and her condition: DHEA supplementation and menopausal hormonal therapy. If there is a patient is menopausal and she is getting vaginal dryness and dyspareunia, then menopausal hormone therapy gives a very good response. So, the crux of management of sexual dysfunction in women with diabetes is good glycemic control, good genital hygiene, and psychosocial optimization and specific interventions like therapeutic patient education, psychotherapy and couple counseling, non pharmacological interventions, and drug therapy. Coming back to good glycemic control, I know everyone has learned by now through these webinars. And the coming to good genital hygiene. In OPD, we tell almost care is almost 100% women are told that they have to keep the genital hygiene in a very good condition, because with this hygiene, they have to keep their area dry, genital area dry. They shouldn't wash their genitalia after every act of urination. Commonly seen that they just wash it and wear their underclothes. Because of repeated rubbing, irritation, get excessive vaginal discharge. Again, itching starts, itching, then because of itching, getting burning and difficulty in passing urine and vaginal infections, and this cycle goes on. So the important point is to tell them, because in diabetes, if it is uncontrolled, if they have taken even just a single episode of taking sweets, sometimes they get hyperglycemia, and that leads to vaginal candidiasis. And so the good genital hygiene is very important. Keep area dry. Don't use water after each act of urination, and that helps controls more than 80% of the symptoms. And if needed, on examination, we can give them local therapy, that is in the form of vaginal pessaries, and if needed, the oral medication in the form of kit, just like Zoconeus kit is there. So that is just to simplify the naming it, and which controls the all bacterial and fungal infection is controlled with it. And sometimes, because in poor glycemic control, the foul smelling discharge is there. Even if discharge is not there, the foul smell is the main complaint. So if we give them the metronidazole tablets, the smell goes off immediately. Even with the single tablet, the local smell symptoms, these go away. So we should take care of that. And about the specific intervention, the therapeutic patient education. So what is that? That means while we are examining our patient, we are telling all these this management issues. So this is a theranostic approach. This should be given in a age-specific manner. We can't tell the same advice to the young girl, maybe of 20 years or so, who wants to plan pregnancy, as we give to the postmenopausal woman. So this should be age specific, relevant to her marital status, sexual habits, and frequency. So these things we have to ask her in history, how frequent they have sexual act, and what is her marital status. Sometimes the couple stays separately. Husband is visiting only once or twice a month. So, what is their frequency, how their habits, and whether she needs to discharge frequently, she gets sexual desire very frequently, and these are unmet desire. So how she should manage all these things? It's this approach should be person specific. This advice also should be person specific. It shouldn't be like a blanket cover. While examining our patient, we should tell her about anatomy and physiology. In my OPD, I have put a chart in which the genitalia that is shown in the picture, and we can tell her. If we don't have that kind of chart, sometimes we ask the patient to give her a phone, and we click the pic and show her that gives her full privacy. She can watch it on her own, because sometimes if the doctor or someone else takes pic from any other phone, so that patient may object. So we just take their phone, show them pic, and delete in front of them if they want. So that is a very good practice in counseling our patients. And role of good glycemic control is very important. We should emphasize that if you control your blood glucose, your all symptoms will be under control. But once you lose your control, the things will become worse. Nowadays, in the marriage season, oh doctor, I have taken party food, I have taken sweets, so that is why I am getting, because 2 3 days I was taking regular sweets, so now I have come with this problem. I am getting genital itching, and I am getting foul smelling discharge. What should I do? So we should emphasize it, because that is an opportunity in which we can emphasize. For other conditions, if we tell them your heart will be good, your BP will be under control, she might not be understanding it. But once this impacts her personal relations with her partner, or there is dissatisfaction in their sexual life, the lady or the couple listens more to the doctor. That doctor is giving good advice for their personal life. That is why she should keep her blood glucose under control. And role of good nutrition and nerve health should be emphasized. For ladies also, we tell them that good nutrition is very important for you. It's not only for your family, but it is for your personal life also. So lifestyle changes, choice of clothing, choice of sanitary products. In summer season, just like wearing jeans, tight jeans, girls coming with the tight jeans and complaining of vaginal discharge. So we should guide them. Yeah, they should wear the cotton-based clothes, loose clothes. Well-ventilated area should be there. Genital should be well ventilated, and choice of sanitary products. Nowadays, the dry feel pads are very common in the market, because for sanitary napkins they use, and these are just dry feel. The doctor, I feel that there shouldn't be any mess. So because of this, if they are getting heavy flow, then all the chemicals applied on their sanitary pads, they absorb the blood. Patient feels good. But once the flow decreases and she uses the dry feel pad or the soaking pads, the chemicals used in them, they just cause pruritus. So we should counsel the person who is coming. Is sometimes the patient comes, after periods I get itching, after periods I get dyspareunia, but in mid cycle things become okay. So that could be a main reason for them. Choice of cleansers and soap, very many products are there in the market. So person specific guidance should be given about the choice of cleansers and soap. The mild soap can be used in genitalia, over genitalia, and they should avoid cleaning their vagina, because that just washes off the normal secretions, and the bacterial vaginosis may come up with it. And once the lifestyle advice has been given, and if we find that our patient, the lady is in perimenopausal or postmenopausal age range, and she is having a dryness of vagina because of estropenia, lack of estrogen, then we can advise the specific therapy about local estrogen cream application, and that is for just genital health. But if she is having all other symptoms, all the phases of sexual health are involved, then menopausal hormonal therapy should be prescribed if she fulfills the criteria for it, for the medical criteria for it. And DHEA supplementation to improve the sexual health, that should also be prescribed. And this can be, DHEA can be given for short time, and MHT maximum up to 5 years can be given, and less than 60 years of age the course should be completed. And its impact is very good if it is started in early menopause. Early means the immediately after menopause, because by that time the hormonal levels are not very much reduced. So that just helps in maintaining the vaginal health as well as the other aspects of sexual health. And psychosocial optimization, definitely the couple based counseling is very important, because if we can't counsel the female appropriately, and we find that she seems to be listening to you, but she is not into the getting what you want to convey, then must call her partner. That will become witness, as well as that person at home will guide her that doctor has prescribed you these things and you should follow. That will improve our health. And the family counseling, we have taken into account the patient and her partner, but at times family involvement is too much, means the sometimes the mother-in-law, that is just conveying mother-in-law, sister-in-law, too much family members, crowded family is there, and there is interruptions are too much, means if the couple goes to her bedroom, even in newly married women, we have commonly seen that they even if they come out of their bedroom, they say, have you done it, have you done it? So they feel very awkward. Just married for 1 or 2 days or 10 to 15 days, they come with a sexual dysfunction. It might not be related to diabetes, but otherwise also the interruptions and interference is too much. So in that case, we can involve the family members, maybe her in-law side or parent side. Sometimes we need counseling for them, and then the couple sexual health improves. If we tell them don't interfere with them, just give them time. For example, one patient came that her husband visits every 2 weekly, but when he comes, her all family members take him for menial jobs, means do this, do that, and we don't get time together, and that is causing dysfunction in me. And I am blamed that I am not involved, sexually involved. So if the partner is not available and partner is busy, means if your mind is not involved in sexual activity, then it is difficult to maintain a sexual relationship. And about the buddy system, sometimes that is very good. So sometimes the sister-in-law or the sister or some other relative, those who are experienced, they can guide, they can guide the patient. And if even if on her husband's side, his friends, they can guide him how to do and how not to do. Moreover, if someone has come as a patient to us and his or her that couple's performance has improved, they just tell their friends that we went to that doctor and that doctor helped us in our sexual life. No other doctor helps us. So that improves our image also, and our confidence as well as our practice. So we should include these things, but just take extra minute out of your practice and you will get very good results. And these things help in support, education, and counseling too. And in psychosexual therapy, relaxation exercises, if there is history of any past sexual abuse, mindfulness, cognitive behavior therapy, these can be given in the counseling session. If there is orgasmic disorder, then sensate focus exercises have to be specifically told. This psychosexual therapy, that takes a longer time than prescribing medication, but this has more impact as compared to the medication. If in the background of psychosexual therapy we prescribe medication, the results are wonderful. If the woman presents with the laxity of sexual flow, the vagina, then pelvic floor training. Sometimes the woman is very conscious, she has delivered vaginally and she has first degree uterine descent. She doesn't want to be sexual, that I might leak urine, or my cervix gets hit. So she doesn't want to go for sexual activity. So then we can fix up the problem, just like pelvic floor training, and then tell her to go for sexual activity. If there is vaginismus, then desensitization. And for dyspareunia, anesthetic gels and creams can be suggested. Even lubricating gels are also very good in dyspareunia. And first of all, try to fix the cause of dyspareunia, and these give the symptomatic relief. And commonly, if desired disorder is there, then vitamin B supplement in the form of sulbutamine B1, that can be given after breakfast. Usually, I give it for 10 to 15 days. Once the patient starts feeling better, then we stop it. And similarly, we can give her yohimbine 6 milligram at bedtime, or sildenafil as given for males desire. that can be given in the form of 25 milligram for the female desire. And for lubrication, the lubricating gels can be used. And if the arginine and yohimbine combination gels are also available, and otherwise antidepressants tablet bupropion 150 milligram OD can be given for lubrication. And the oxytocin nasal spray is under, it's not marketed as yet in India. And for the postmenopausal women, for genital health, because they get estropenia, there is vaginal dryness. So then we can give them estrogen tablets, estrogen vaginal creams and gels can be given to be applied daily. The vaginal creams and gels are to be given daily for 2 weeks and then twice a week. That can be used for minimum is 2 months, but can be continued for a longer time. DHA has very good response, can be given at bedtime. And testosterone gel, which is available for males, that can be applied in the 1/4 dosage. For males, if we take the 1 point and then 0.25, means just 1/4 dose is enough for postmenopausal sexual dysfunction in the woman. And ospamifene, that is 60 milligram per day, that can also be given. And if orgasmic disorder is there, then psychosexual therapy, as discussed earlier. Other things to attain orgasm, devices are available in the market in the form of vibrators or energy-based devices like radio frequency and laser. This can be suggested, these procedures. And office procedures are also there. So nowadays, the cosmetic gynae, surgical and non-surgical procedures, these are very much common and easily available. Almost in all of the cities, one or two gynecologists or even dermatologists or even dental specialists, those who are coming in cosmetology, they are having and giving their patients G spot, O shots, and labioclitoral fillers. So these can be suggested to them. But commonly prescribed medications and psychosexual therapies, these are effective. But those who are very conscious about their sexual dysfunction and don't feel satisfied at all, then these things can be tried. There is another condition specific to diabetes, especially uncontrolled diabetes. The patient comes with a complaint of burning over genitalia. And when you examine her, you don't find anything at all. Her vagina is healthy, no vaginal infection, and she is complaining of day in and day out that I am getting burning over my vulva, I am unable to pass urine, I am unable to sleep. In those cases, when all other organic causes have been ruled out, then we should think of vulvodynia. So that might be a symptom of painful diabetic neuropathy localized to vulva. So then if we specifically look for vulvodynia and we have found all other things normal, then local examination, we can go for the cotton swab test and tampon test. We should take wet mount and culture if we suspect any underlying infection. And locally applying the GABA mix gel that is effective for it, estrogen cream and oral medications can be given to her. And these patients, if there is no response with this local therapy, then she should be offered PRP, the platelet-rich plasma therapy, laser therapy, or radio frequency can be suggested to her. So once we have seen means how we can just pinpoint that which type of problem the patient is having, because in our busy OPDs we don't have much of time. So simple, these 4 conditions, if we divide all these conditions into these 4 points, then it will be easy for us to manage and give her treatment properly. So if woman presents with a low libido and low motivation or inclination, she says, I don't have desire and I don't want to be sexually active, she might just look for her blood glucose control. She might be having poorly controlled diabetes. At times, she says that I have low desire, but once I am provoked, means I am stimulated, then I get motivated and I have high level of motivation. But somehow, even if I start, I don't complete the procedure, I don't get satisfied with the sexual act. So then assess her other hormonal status like her testosterone level and prolactin. Sometimes the hyperprolactinemia leads to difficulty, means there is low libido and inability to perform. And at times there is normal libido but low motivation. The person says that I want to become sexual, but I feel lethargic, I don't want to do it. Maybe with a particular partner, then we should assess her psychosocial relationship. Means if her libido is okay, but she is not inclined to be sexual with her partner. So sometimes they have a fight because of some trivial issues, because of children, because of family matters, because of financial reasons. So we should look for those psychosocial factors. And if she has normal libido and normal motivation, even then she is not sexually satisfied or her partner is not satisfied with her act, then must look for her complications of diabetes on her or other concomitant conditions, like if she has some vasculopathy or there is local problem. She might be having one of my patient, young patient in fertile age group, she was having agglutination of her labia. So, in those cases, if there is normal libido, normal motivation, and inability to perform, must examine her local genitalia. And once that agglutination was over, that is just released, and sexual act became okay. So, just to summarize, female sexual dysfunction is underdiagnosed, underreported condition. Patient herself doesn't come up with the problem, doesn't complain directly, and we don't ask her, so things just go under the sheet. It is more common in diabetes, so we should address it proactively in our patient care, and it can be treated with therapeutic patient education, medication, and minimally invasive therapy. So, optimizing sexual health improves the glycemic control and quality of life. Believe me, if sexual health is okay, their sexual partner's sexual relationship is okay, she feels happy because that releases the endorphins and all these hormonal changes. These lead to a better glucose control. She feels like taking care of her diabetes, and moreover her energy level improves, and she takes herself good care of herself and her family. So that is a long way to go, and long impact is seen with the improved sexual health, especially in females. So male partner we will discuss it later, but for female it is very important. So now coming to the quiz question, that is the time for quiz. So what is an essential aspect of diabetes management to minimize the impact on female sexuality? The option one is avoiding emotional intimacy, regular monitoring of blood glucose, ignoring any change in sexual function, and consuming high sugar foods. Just answer it fast. So the essential aspect of diabetes management to minimize the impact on female sexuality. And another one is, which of the following can be potential impact of diabetes on female sexuality? Diabetes on female sexuality: increased libido, improved sexual satisfaction, decreased lubrication and arousal, and enhanced fertility. I think these two questions are very, very easy, so everyone should get a prize for it. I hope everyone will answer it correctly. Thank you.
Thank you, Dr. Bharti, for that wonderful talk, wonderful presentation. And this has stimulated a lot of interest in women's health from our friends across the country. And greetings to you from Dr. Anshul Singhai from Chhattisgarh. Sachin Mane, we acknowledge all the questions you've put in, and many, many more people who have asked questions. Dr. Ashok Kumar Sharma, Dr. Devraj Dholaria, Dr. Surinder Gupta. Please allow us to take the questions related to women's health today, and we acknowledge all the other questions. We'll handle them later. Dr. Surinder Gupta says he points out that weakness is often a word that is used to indicate sexual function. And now in practice, young women are still more forthcoming. They are able to share their symptoms. But in the 50 plus age group, it is difficult to take a history, especially if you are a male healthcare provider. Would you like to, Dr. Bharti, speak for some Hindi equivalents, Hindi euphemisms for weakness, where if, let us say, the person speaks in Hindi, the doctor can get an idea that this is what the patient is trying to convey?
हिंदी में ज़्यादातर जो लेडीज़ हैं जो मिडल एज वाली लेडीज हैं वो ये बोलती है कि कमजोरी, वीकनेस का एक कमजोरी तो है। कमजोरी ऐसा नहीं कि दिन में घर का काम तो हम अच्छे से कर लेते हैं, पर रात को बहुत थकावट हो जाती है, बहुत कमजोरी होने लगती है, मन नहीं लगता, इच्छा नहीं होती। ये डिफरेंट वर्ड्स हैं जो कमजोरी नहीं, मतलब इन विच दे वांट टू कन्वे दैट दे हैव लेस ऑफ देयर सेक्सुअल डिजायर। और इच्छा, सुकून, कभी बोलते हैं हमें सुकून नहीं मिलता, तृप्ति नहीं होती। हिंदी वाले वर्ड्स में तो वो इस तरह से बोलते हैं।
Yeah. And Dr. Devraj says, will vitamin B12 help?
Yes, vitamin B12 also helps because that helps in the neuropathic features.
And Dr.
अदरवाइज भी हम
Shashi,
डायबिटीज वाले पेशेंट अदरवाइज भी डायबिटीज वाले पेशेंट्स में हम विटामिन बी सप्लीमेंटेशन देते हैं, दैट इज टू बी गिवन टू देम बिकॉज ऑफ विटामिन बी डेफिशिएंसी।
Dr. Shashi Khare has a question. In menopausal women, can we prescribe estrogen gel for dryness of vagina? And to
Yes,
this, maybe I can add a question. What are the minimum tests that must be done before prescribing this?
for prescribing vaginal gel, normally no tests are required for vaginal gel. If we have to give menopausal therapy, जो हमें oral अगर therapy देनी है, because that has systemic effects, उसमें हमें टेस्ट की जरूरत है। दैट इज फॉर गुड ग्लाइसेमिक कंट्रोल, फॉर गुड ग्लाइसेमिक कंट्रोल्स, डायबिटीज रिलेटेड टेस्ट। एंड अदरवाइज जो हम अल्ट्रासाउंड, जैसे हमने पहले बताया कि अल्ट्रासाउंड करवाना है, पैप्समियर, अगर हम लोकल उसका एग्जामिन करते हैं तो हमें पैप्समियर करवाना चाहिए, ताकि अगर कोई हिडन कोई उसमें सर्वाइकल कैंसर या कोई abnormal सेल्स हैं, दैट शुड बी रूल्ड आउट। और वजाइनल एग्जामिनेशन इज इम्पोर्टेंट फॉर दैट, कि उसी में ही हमें पता चल okay the if there is cervical health, for cervical health we should go for the pap smear, and for the pelvic health we should get her ultrasound done. And sometimes the for if we have to prescribe the oral MHT, menopausal hormonal therapy, then lipid profile is to be done. And the otherwise, we for the hormonal status we do for the testosterone and FSH levels, whether she has attained menopause or if she is likely to bleed or not, that we have to convey to her. If endometrial thickness is more, because if she has attained menopause, her endometrial thickness will be less than 4 mm, which is normal. But if it is more, then we should be very cautious in giving her menopausal hormonal therapy. It's preferable that we should do her endometrial sampling to rule out any hidden endometrial cancer or any endometrial hyperplasia like changes.
Dr. Shashi has another question. She says that dyspareunia is quite frequent in young married women. So, two questions. What is honeymoon cystitis? And second question, what medications are given for treating dyspareunia?
The honeymoon dyspareunia is very common because if first exposure to the sexual act is usually painful because the hymen rupture is there in the first sexual contact. If it is there, sometimes it has already torn, then it is dyspareunia may not be there. Because of fear, the psychological factors are important in young women in the sexual relationship, because there is fear of pain. So that causes the dyspareunia, that she might be having vaginismus because if she is unable to cooperate in her sexual act. So dyspareunia might not be alone a thing. It might be related to the vaginismus on her part. So that is a common condition. And the first intercourse and the forceful intercourse, or if she has a fear in her mind, there will be lack of lubrication and lack of difficulty in penetration. So this is for the young girls, and we should examine her. Sometimes the very rare conditions, she has amenorrhea and she gets married, and she was never examined for her local genitalia, whether she has some vaginismus or she has absent vagina. These things rarely happen, but we should examine her locally for that. And if there is dyspareunia, she is not cooperating, then we have to tell her the taking in sexual act she should go for the foreplay that and be relaxed. If she is mentally relaxed, she will get the lubrication and it will be easy for penetrative sexual relationship. And about honeymoon cystitis, because this part has never been used before the sexual activity. Commonly, this part is not used. So, on first exposure for the sexual act, she gets the urinary infection. That is a common if the hygiene is not well maintained, the sexual act is not properly done. She gets urinary infection. Usually, it is named honeymoon cystitis because that happens with the initial few intercourses, and then we have to treat it if we treat it early, because if we don't treat it early, that may lead to pelvic inflammatory disease. If we treat it early, so that will control her infection part, and she will not get dyspareunia and the frequent urinary symptoms after the intercourse.
One question from Dr. Gauri Shankar. Sir, we request you to allow us to do a separate KK talks on this, and the question is menopause management, which will be a long topic. Good ECG book. Shamroth is what I have used. Shamroth is a very friendly ECG book, and I would suggest that for general practice. But there would also be a book called ECG Made Easy. So search for that, ECG Made Easy or ECG by Shamroth. Trimetazidine and ranolazine both are anti-anginals. You can use them in patients with chronic stable angina. Anybody with unstable angina, that means sudden increase in frequency or severity of angina, we should refer to the cardiologist. But if patient is stable, chronic stable angina, trimetazidine and ranolazine both will help in reducing the symptoms. A warm good evening to Dr. Siddharth Dangar. And Dr. Bharti, there's an assalamu alaikum for you from Pakistan, from Miss Fatima, who is a nutrition student there.
Welcome, Assalam.
Thyroid, if TSH has gone from 15 to 0.002, we can reduce from 100 microgram to 75 or 88. You can reduce to 75, Dr. Gauri Shankar. Do not stop and check the TSH again after 45 days. Thank you, madam, from Dr. Ajay Kumar Lal as well. If TSH has come from 15 to 10 and patient is still symptomatic, then we can increase 100 to 125. And tiredness and fatigue, Sachin Mane, please allow us again to have a separate KK talk on what we call diabetes fatigue syndrome. One question from Dr. Gauri Shankar is, in general practice, we see a lot of patients complaining of itching, pruritus vulvae. So what are the treatments for that? And can you please suggest a syndromic approach? Because as a male healthcare professional, I will not be able to examine.
So, one syndromic approach, the simplest one, if for a male gynecologist, if that has to prescribe, they can give the kit, which contains secnidazole, azithromycin, and fluconazole. These the combination of these three will take care of her the bacterial vaginosis part with the secnidazole and trichomoniasis along with it, and the antifungal for the candidiasis part is taken care by antifungal, and azithromycin and metronidazole, the secnidazole or metronidazole, these take care of the vaginal part. Vaginal bacterial infections, and along with it you can prescribe her the probiotics. So give her that kit. She has to take it because in this kit it is written take it empty stomach. For each tablet it is written it should be taken empty stomach after meal with meal, and once a day probiotic if given for 10 days. During that time her symptoms should disappear. And tell her about the local hygiene. As already told, that keep the area dry, don't wash it again and again, and if possible use toilet paper or some old towel. Usually in homes they keep for themselves separate towel, with which they just wipe off the extra urine drop which passes in the females. In males the all urine once passed it's clear, but for females just 2-3 drops just trickle after that. For that they usually wash the area, so that should be avoided. Just wipe it that part, so that will keep the area dry, hygiene will be good, and pruritus will reduce.
And one more question is, endometrial thickness 12 millimeter. What is the significance? But Dr. Gauri Shankar sir, if you can specify the age of the patient, and you will also have to specify how many days since the last period. So because it will vary according to uh, the date of the cycle, and let us say it's a postmenopausal woman, then the approach is totally different. And if it is a young lady, maybe who is at 15th or 18th day of periods, then it is a very relaxed kind of an approach. Some questions let me take. IV to subcutaneous, we will shift when patient is ketone free and symptom free. And before stopping the IV, maybe half an hour before stopping the IV, you have to give subcutaneous insulin, because subcutaneous insulin, even rapid acting, will take half an hour to act. So let us say you give subcutaneous insulin at 1 p.m. and patient is going to take lunch at 1:30 p.m. Continue the drip up till 1:30 p.m. Whatever rate you were giving earlier. Uh, Hyperthyroidism is very big topic. Anshul cannot do in few words, please. So maybe next time. One question for women's health: can we prescribe sildenafil 25 milligram daily to a postmenopausal lady with diabetes?
Why we want to prescribe sildenafil? That should be a question. If we want to give her for her sexual health, that can be given. But if we give it for a long time daily, that is not a good indication, because for some time, for short time, if we start it and she becomes sexual and she increases her frequency of sexual activity, the need of sildenafil will reduce and it will just omit, because that helps in lubrication and the improving the desire. So sex begets sex, simple thing. If she starts with it, it's no need to continue it for a longer time. 25 can be given.
Few more questions. SGLT2 inhibitors affect female genital health quite frequently. People in other parts of the country, endocrinologists say 5 to 10%. In my experience, it would be 10 to 20%. So anyone whom you are planning to start on SGLT2 inhibitor, do take a history first. And even when the patient comes back, do softly inquire about any genital symptoms. Dr. Vilas Sonavane asks, patient of CA breast on letrozole, what should be your advice? So mine would be, Vilas, to continue the letrozole and not to stop, to follow the oncologist's advice. But maybe we can ask Dr. Bharti, a patient on letrozole, will that impact genital health?
The If she gets the sexual symptoms, means if there is lack of desire or lack of orgasm, and if she gets dyspareunia, then we have to give her symptomatic treatment for that. Otherwise,
And,
DHEA can be given for short time.
and local treatment will be safer, Vilas. So, like instead
Yes.
of giving an oral estrogen, because then there'll be a lot of hormonal cocktail in the body, local estrogen would be preferred here. It will have only local effect. One very pertinent question from Dr. Lambe, and then we'll take one more question from Dr. Anshul. So, Dr. Lambe says, Madam, patient is allergic to sulfa, to secnidazole, metronidazole, and we see this quite frequently. Then, what is the option we have for vaginosis?
Doxycycline and probiotics plus local therapy, that is in the form of vaginal pessaries.
Thank you.
In this, we can, depending upon which condition, because the sertaconazole pessaries are there, which are effective for all these kinds of infections, means the bacterial as well as the fungal infections. These take care of these two. So that is to be given if we are given once today, and then it's to be repeated after 3 days. Just two applications are enough.
One tough question, and this is from Dr. Anshul. We will take this as the last question if everybody allows. And Dr. Gauri Shankar, thank you, sir, for your kind words. The message for Dr. Bharti, the request is, Madam, please talk on more topics in diabetes essentials. This request is from Karnataka. Anshul from Chhattisgarh has a question, and I also have the same question. This is one of the most challenging things in practice, especially with the women with type 1 diabetes. So he says, Ma'am, we come across patients with premenstrual syndrome, and during this time, it worsens glucose control. In fact, there is something known as catamenial seizure disorder also. Some people get seizures or seizure-like episodes during the premenstrual syndrome, and the fasting glucose rises very high. So, how do we counsel these patients with premenstrual syndrome, and how do we manage them?
So for counseling part, because there is a condition of PMS, premenstrual symptoms, and PMDD, premenstrual dysphoric disorder. So we have to assess whether the patient, because if she has catamenial symptoms, so she is landing up in premenstrual dysphoric disorder. So we have to manage it separately. If she has mild symptoms, just like premenstrual symptoms, then we have to give her, first we have to counsel her, because these are because of hormonal changes, because of progesterone. Because of the later half of cycle, you get high level of progesterone, and because of that hormone, you become lethargic. That causes the fluid retention in our body, and that the fluid retention is seen in breast in the form of breast tenderness, blotted feeling, puffiness of face, and irritability, increased irritability. So that can be controlled. That is just counseling part, and with this we have to tell them that dietary advice is mandatory. We have to tell them if you get these symptoms or in the from the mid cycle onwards, you should avoid taking the fast food, junk food, spicy food, because excessive intake of salt and spices that causes the more fluid retention in our body and worsening of our symptoms. Plus, along with it, if they take excess of caffeine, sometimes the girls start taking excessive of chocolate. That I don't know what happened. I have started eating chocolate. I feel like crying, and I have started taking coffee. Excessive of coffee, intake of coffee. So that worsen the symptoms. So counseling, then dietary advice, then tell her to go for light exercises. Exercises should be continued. And then we can give her medication in the form of the vitamin pyridoxine, high dose of vitamin B6 that helps in controlling the symptoms. And there is one study in which the high dose of vitamin D, 60,000, 30,000 units for 5 days prior to menses, that helps control these symptoms.
That is also a good idea. So we can choose to supplement vitamin D premenstrually instead of routinely. Thank you, madam, so much. And I thank everybody for all their pleasant comments. Dr. Gauri Shankar says, unexpected surprise knowledge that I gained today. Dr. Gauri Shankar, let me add my voice to yours. I have also learned a lot today. And madam, thank you and sincere regards from everyone across the country. Dr. Anshul, Dr. Lambe, Dr. Siddharth, and so many people who have logged in today. What I have realized is that actually in a diabetes clinic, half of our patients are women, and we ignore so many things about women's health. It is not that the male healthcare providers do it on purpose. It is not that there is a bias. It is just that there is a lack of information, maybe lack of awareness, and perhaps communication is not so good with the lady patients. So perhaps as we speak more and more about this, we will be able to improve our conversation skills in the OPD as well, with both men and women, with people of all genders, and that will help us create a much happier and healthier India. Madam, it's more than 1 hour now. We appreciate your time, your expertise. But what final message would you have for everyone, all our doctors managing diabetes throughout India?
I will first like to convey thanks to the this webinar, because I have also come across just touching up so many lives of doctors. Means once we gain some knowledge, we want to spread it. We want everyone should know it. Uh, in being a gynecologist, I have come across all these kind of patients and I have managed them. I want feel confident. Means just gain knowledge and be confident. If you start asking even one or two of your patients, if you make a aim that today in my OPD, if just I will ask the sexual health related questions in from my just two patients, so that will improve the communication, as Dr. Sanjay has already told, that we should start asking them, and we should start in our back of our mind, we should have this thing that we want to explore, because if this patient is poorly controlled diabetes, we should rule out her sexual health problem. So if we start asking, we will know more of the problems our patients are facing, and we will help them better in controlling their blood glucose levels and making them happy in their life. So just start asking, and just before asking, just think that we have to ask this question. As we do that in gynecologist OPD, it is recommended that at least do 2 pap smear a day. For even HPV vaccine, if you try to touch just two lives, if the two women are coming to you and they have their girls in adolescent children, girls or boys in their adolescent age group, just make them aware of about HPV vaccination. Similarly, if even male or female, all type of physicians, those who are taking care of diabetic patients, if they start thinking of it and start asking just their patients, so that will improve their confidence, their patients confidence, and their practice too.
That is a very nice take home message and something that we can all follow. Supposing, as you are not comfortable speaking with the patients, you can ask their husbands as well or their partners. That is a nice way to begin. begin by asking people who are relatively elderly or people of your age. So it depends upon whatever social setup you are in, but at least make a beginning. And this beginning, if all of us do it together, it will lead to a revolution actually in healthcare across the country. Thank you once again, madam, and I'd like to thank Team FDC for being with us. And as usual, Mr. Basu is with us. Mr. Basu, how was your day? How was your weekend? You're muted, sir.
So, sir, I was staying in home. I mean, there is no weekend for us. Tomorrow is our usual working day. And as I've been habitual attending your seminar every Sunday at 9 p.m., and we are continuing it for the third year consecutively. And Dr. Bharati Kalra has today taken a very comprehensive session. And the accolades, you can see, Dr. Bharati also can see on the screen that the accolades are coming across India for the wonderful lectures he has taken. I would just like to add that as India is progressing and the GDP is increasing, more women workforce will be adding to India's growth, which will make this relevant topic today more difficult because all physicians and pediatric doctors who are treating diabetes will see more working women coming up with diabetes and female sexual disease and disorders as well as mental disorders. So today's topic, what Dr. Bharti has given us a take-home message, and Dr. Sanjay Kalra has added that start at least in that line will improve the mental as well as socio-psychological health of the women as well as the entire society. That's the possibly the outcome of today's webinar. And because of that, I would definitely like to thank Dr. Bharti for taking such a wonderful and lengthy session today. And obviously, all credit goes to Dr. Kalra because I mean, sincere thanks to him because last week itself he has designed all the uh, topics which is to be taken for next 3 months. In that, he has already taken this topic as a prime importance, and all the other topics will be also so engaging in coming days. With this, I sincerely thank Dr. Bharti with being with us and looking forward to be in other sessions as well because sir has already designed such more sessions into this. We will be very happy to welcoming you in our session. And at the end, we obviously my beloved Dr. Sanjay Kalra. Thank you very much, sir, and good night and Jai Hind, sir.
Merry Christmas and Happy New Year to everyone. Perhaps we'll take a break for 31st December so that
Yeah,
everyone can enjoy at home and we join you again on the first Sunday of January. But
yeah, this is the
Merry
best
Christmas,
amount to do.
Happy New Year, and Jai Hind, everybody.
Jai Hind.
Jai Hind.